Welcome back to the channel, where we turn complex disease into clinical clarity. I'm Dr. Rizayan, specialist in arthritis and rheumatology, and today we're taking a deep dive into granulomatosis with polyangiitis, formerly known as Wegener's granulomatosis. Before we begin, this video is for education and inspiration only. It's not medical advice. Be sure to consult a healthcare professional and double-check information with trusted sources. This isn't just sinus inflammation gone rogue. This is body-wide, tissue-killing, granuloma-forming blood vessel inflammation, and it demands our full clinical attention. Granulomatosis with polyangiitis is a rare autoimmune disease that attacks small to medium-sized blood vessels, with a destructive preference for the upper airways, lungs, and kidneys. It belongs to the ANCA-associated group of vasculitides, along with microscopic polyangiitis and eosinophilic GPA. Let's go cellular. GPA is driven by PR3-ANCA. These are antibodies that activate white blood cells called neutrophils, triggering them to release enzymes and oxidants. The result? Blood vessel damage, cell death, and granulomas, especially in the sinuses and lungs. Key players include PR3-AA, which targets proteinase 3, MPO, a less common antibody, steps like neutrophil activation, adhesion to vessel walls, and release of toxic granules. Pro-inflammatory signals like tumor necrosis factor alpha, interleukin-6, and interferon gamma. The complement pathway, especially C5a and its receptor, amplifies inflammation. Also important, some patients have genetic risk factors like certain HLA alleles, and exposures like silica or infections may trigger the disease. GPA attacks many systems unpredictably. Let's go organ by organ. ENT, or ear, nose, and throat involvement, occurs in about 90% of cases. Chronic sinus inflammation, nasal crusting, frequent nosebleeds, damage to the nasal septum leading to saddle nose deformity, narrowing of the airway below the vocal cords, middle ear infections, and hearing loss. Lungs are affected in 70 to 85% of patients. Cough, sharp chest pain with breathing, coughing up blood due to bleeding in the lungs' air sacs, cavities forming in lung nodules, scattered migrating spots on lung imaging. Kidneys are involved in up to 80% of cases. A specific type of kidney inflammation that doesn't involve immune complex deposits. Blood in the urine, protein leakage, and rising creatinine levels. Often has no symptoms early on. Eye findings include inflammation of the white part of the eye, redness, irritation, masses around the orbit that can mimic tumors. Muscle and joint symptoms, moving joint pain, muscle aches, nervous system signs, multiple damaged individual nerves, numbness or weakness in the limbs, raised purple spots due to bleeding under the skin, a net-like discoloration pattern, reduced blood flow causing ulcers or cold fingers and toes. To diagnose GPA, we look for clinical patterns, blood tests, imaging, and ideally a biopsy. Blood tests include PR3-ANCA, highly specific and sensitive, C-ANCA pattern on immunofluorescence, PO, more often seen in microscopic polyangiitis. Inflammatory markers like ESR and CRP are almost always elevated. Complete blood count may show anemia, high white cell count, or increased platelets. Urine testing may reveal blood or protein. Blood creatinine is monitored to assess kidney function. CT scan of the chest shows cavities or bleeding in the lungs. CT of the sinuses may show bone destruction or thickened lining. MRI or CT of the orbit or brain is used for specific symptoms. Lung biopsy typically shows the classic necrotizing granulomatous vasculitis. Kidney biopsy confirms the specific type of inflammation seen in GPA. Sinus biopsy may be less clear but still helpful. Before diagnosing GPA, rule out other conditions. Microscopic polyangiitis lacks granulomas and affects kidneys more prominently. Eosinophilic GPA features asthma and high eosinophil counts. Sarcoidosis has granulomas but no tissue death. Tuberculosis or fungal infections can mimic lung cavities. Cocaine-induced vasculitis can destroy midline tissue and cause false positive ANCA tests. In treating GPA, acting fast is critical to preserve lungs and kidneys. The first phase is called induction therapy, aimed at achieving remission. For severe disease affecting organs, start with intravenous steroids, 500 to 1,000 milligrams of methylprednisolone daily for 3 days. Then switch to oral prednisone with taper. Rituximab is usually preferred, given either weekly for 4 weeks or in 2 higher doses 2 weeks apart. Cyclophosphamide is used when rituximab isn't available, but needs close monitoring for low blood counts, bladder damage, and infertility. Avacopan is a newer oral drug that blocks C5a receptors and helps reduce steroid use. Plasmapheresis or plasma exchange used to be more common, but large trials show it often doesn't improve outcomes. For milder disease, methotrexate plus steroids is effective. Mycophenolate mofetil is another option if methotrexate isn't tolerated. Once remission is achieved, we shift to long-term treatment to prevent relapse. Maintenance therapy options include rituximab infusions every 6 months, shown to work better than azathioprine. Azathioprine is taken daily by mouth. Methotrexate can be continued if kidney function is stable. Mycophenolate is used when others aren't tolerated. Steroids should be reduced gradually to 7.5 milligrams per day or less over 6 to 12 months. Most patients need maintenance for 18 to 24 months. Those with frequent relapses or PR3-ANCA positivity may need longer. Monitoring GPA requires close follow-up. Clinic visits every 1 to 3 months during early treatment, every 3 to 6 months during maintenance. Lab tests include ANCA levels, not always reliable, but sometimes helpful. CRP and ESR to track inflammation. Regular checks of blood counts, liver function, urine, and kidney markers. Urine protein to creatinine ratio helps track kidney damage. Imaging may be repeated to monitor for return of lung or sinus disease. We also use standardized tools. The Birmingham Vasculitis Activity Score to track disease. The Vasculitis Damage Index to measure long-term effects. Patient-reported symptoms like fatigue, sinus pain, and nerve pain are important too. We also monitor quality of life using surveys like the SF-36. The future of GPA treatment looks promising. Avacopan leads a new class of C5a blockers. BTK inhibitors target B-cell activation. CAR-T regulatory cell therapy is being explored to reset immune tolerance. IL-6 blockers like tocilizumab are under study. JAK inhibitors like tofacitinib are still experimental, but may help in stubborn cases. With modern treatment, 5-year survival is over 80 to 90%. Relapses occur in about half of patients, especially those with PR3-ANCA. Long-term damage often includes kidney disease, nerve pain, sinus problems, or hearing loss. Deaths are more often due to infection or heart disease than active vasculitis. Key takeaways: ENT, lung, and kidney symptoms. Think GPA. PR3-ANCA is a major clue. Rituximab is first choice for both starting and maintaining treatment. Avacopan helps reduce steroid exposure. Follow-up must be based on the whole patient, not just lab results. And that's your complete guide to GPA. If you're a student, trainee, or just fascinated by autoimmune diseases, be sure to like, subscribe, and click the bell so you don't miss what's next. From vasculitis to vital signs, we bring medicine to life. See you next time.